I'd like to welcome Euan Ashley. He is the co-director of the Stanford Data Science Initiative, as well as faculty in medicine and biomedical data science, and courtesy faculty in pathology. His group focuses on the science of precision medicine, and he leads a team that carried out the first clinical interpretation of the human genome and routinely applies genome sequencing to the diagnosis of patients at Stanford Hospital, where he also directs the Clinical Genome Service and the Center for Inherited Cardiovascular Disease.
Sounds like too many jobs.
Yeah, you and me both.
Yeah, right. Sounds familiar. Well, welcome. It's wonderful to see everyone. I see a few faces I recognize from previous events, so it's great to see you here. And happy to kick off the second day. Thanks to Erica and the team for putting this on. It's really, from the faculty standpoint, a great opportunity for us to have time to interact with industry partners. So I'm going to, although as you just heard, I spent a lot of the last 10 years of my life focused on genomics for health. We have also spent quite a lot of the immediate last few years working on digital data tools for precision medicine and precision health. So I'm going to talk a bit more overall about that right now. I think maybe there's one slide on genomics, but I think otherwise this is it. This is a slide I like to show. It's a bit small for you to make out all the individual countries, but essentially, as you can see from the axes, it's the number of mobile phones per person and GDP per capita. Each country is a circle, and the size of the circle relates to the size of the country. The key thing, of course, is that the line of unity goes right through the middle, and you can see that very many countries, first of all, not surprisingly perhaps, countries with high GDP have more than one mobile phone per individual. Up here, Macau has more than 3 mobile phones per individual, which I always find quite amusing. Given you have only 2 hands, I'm not sure what you do with the third one. I was visiting Hong Kong recently and was able to ask them if they thought this was real. It probably was from the audience response. More than 2 phones per individual in Hong Kong. But what and you can see India and China in here, and then the US is around this line of unity as well. What I think is much more important from a global health standpoint, and quite interesting from the perspective of high technology and world health, is the fact that so many of these countries down here with significantly less GDP per capita are also not that far away from the line of unity of 1 mobile phone per person. So there are African countries here like Liberia, Zimbabwe, Rwanda, Afghanistan's down here, Mozambique. So countries really where increasingly the most significant disease, the biggest killer in these societies now no longer infectious disease, but is actually cardiovascular disease. And I'm a cardiologist among the other jobs I have. So I work here at Stanford Hospital in cardiovascular medicine, and we are very interested in applying digital tools to improve cardiovascular health. And we tend to think of that as a developed world problem, but in reality, increasingly, as we understand, in almost everywhere across the world, the major cause of death is cardiovascular disease, and particularly heart attack. So we'll talk a little bit about that. And the key thing, of course, is can we use these devices, mobile phones being just one, to improve global health? Because not only do we have these devices in our pockets across the world, but of course we actually quite commonly are looking at them. And 52 times a day. I think I saw another study from Google that suggested the number of touches that a phone receives is about 1 million in a year, which is several hundred in a day. It's not a surprise if you look around the world that this is the case. And of course, for the most part, people are looking at social media or their photos or catching up with friends in a variety of other ways, perhaps reading the news, watching YouTube, whatever. The question is, can we grab their digital attention to improve their health? And that's a lot of the focus for us. And you'll see a number of slides from what began as a collaboration with Apple, and we still work pretty closely with Apple, so you'll see some pretty up-to-date data actually just from last week that I'll show you at the end from that collaboration. Some parts of this have been entirely focused independent of Apple in Stanford alone, and some have started and ended as collaborations. And so the first study I'll show you was started as a collaboration back in 2014. Our app, which was called My Heart Counts, still available, was launched by Jeff Williams on stage at the Apple event Spring Forward in March 2015. And basically the idea was to harness the the technology in the phone, particularly the phone, because the watch had at that point not been released, to try to improve cardiovascular health, and use it specifically to prove that using by approaching clinical research. And clinical research has a number of aspects that were not being dealt with that well with old school technology. So when this was launched, we know we're used to in academia, particularly trying to do studies with 100 people. If we get to 500 people, we're very happy. Usually we have these posters around campus that you'll see where there's a phone number on the bottom, and you tear them off and you call the research coordinator. Then you go find a parking spot and you go into some office that you can't find, and you sit down and you spend 45 minutes learning about the study. That's how we do this today, and that's why it's quite hard to even recruit a few hundred people. But of course, if Jeff Williams, the CEO of Apple, announces something on stage, it turns out 40,000 people sign up just over the course of a few weeks. And so we built this app really with just 2 or 3 people. Of course, the software dev team, in this case, that Apple had helped us find. But we ended up with a study with tens of thousands of people in it, and only 2 or 3 people ready to deal with that data. So we had to learn quite quickly. Probably the most important thing was to be able to take that long process that I just described of doing consent, like an hour-long process, and putting it onto a phone. And so we essentially reproduced the classical IRB-based consent in a number of different screens that could be seen on a phone. This is all, of course, this code is also all open source, so anyone who wanted then, from then on, to do a clinical research study on the ResearchKit platform could essentially just scrape our code, change the words for their local environment, and then move forward with their study. And so this idea of electronic consent is something we wrote about in this article, if you're interested in seeing more. Part of it is putting the power in the hands of the participant and really thinking of the participant as a partner in the study, because traditional medical studies were not based that way, and we didn't think so much of, we called them subjects, people who joined our studies, and that's really the wrong way to think of a potential research participant. So having the power in your hand means the ability to share or not share your data at any time. And so that's something that obviously made easy by this technology that was not easy before, when it was mostly paper-based. The watch came out in the middle of this study, so we started to essentially just spontaneously get watch data as well as phone data, which was good. And this is the paper. I'll not spend too long on it. It came out a couple of years ago now. Really just a demonstration that we could use this kind of technology to do a clinical study. And the clinical study, it was basically 7 days, questionnaires every day, and a 6-minute walk fitness test at the end. And I'll show you some data from that. 6-minute walk is just exactly what it sounds. How far can you walk in 6 minutes? It's normally done with a cone and a nurse in the hospital, or little orange cones, and a nurse having someone walk back and forth and have a stopwatch. Of course, the phone knows how to count to 6 minutes. It knows how to count steps. It knows distance. You can do it inside and out. You can do it whenever you want. So we learned also very early on that one of the major challenges, and again, the text is a little small for you to see, so I'll give you the key numbers. But engagement is the hardest issue with doing these kinds of research studies, because we did indeed start off with 48,000 who consented. In terms of those who uploaded data, we're already down to 40,000. And by the time we get to the end of 7 days, there's only 7 days later, we're about 5,000. So we lost an order of magnitude of individuals in terms of their engagement with the study. Now, 5,000 individuals is still tenfold the size of the largest 6-minute walk study that we've been able to find prior. So that's still a pretty good improvement. But we had essentially lost 1 order of magnitude in order to gain 1 order of magnitude on what was there prior. And that's really a theme that has followed through our work over the last few years in this area. One of the key things about sensor data, of course, I don't really need to tell anyone in this room, but it's much richer data. And whereas before we'd have questionnaires saying, how much did you walk last week? How many flights of stairs do you think you walked last Tuesday? Now we actually have the data, both the pattern data and the quantity of data. And usually these are triaxial accelerometers, pretty standard, and we're looking at, for the most part, fairly standard metrics derived from that, the area under the curve being the primary one. But of course, we actually have the data. We also have transition state data, so the low-power chip that's built into the phone and the watch essentially outputs a transition state, outputs a state, and we can obviously pull out the transitions and look at how much, not only how much overall people are moving, but how much they transition from, say, sitting to standing to walking to running to getting in their car. And so it's just a much richer data set to look at physical activity, and physical activity is really one of the primary determinants of cardiovascular health and fitness. So just as a simple example, we can take weekdays and sorry for those of you at that side that don't see maybe I could do it online. Here, get the cursor, does that appear? Yeah. So you can see, this is just a straight clustering algorithm. And basically we have those who were spending more time stationary in blue and less time stationary here in orange. And then we can map this, and this is something that took almost a decade when it was originally done in the 40s and 50s. It's not new news, but you can map that essentially to the diseases that people tell you that they have, and not a surprise. There's both a causal arrow going in both directions, that inactivity causes disease, but also then disease causes inactivity, and this came out very rapidly from this data, as you can see in here. But I think there's major advantages to having the computer essentially cluster individuals rather than us overlay our human sense of it. Of course, we're interested in things that we weren't able to do with the prior technology, and transition states, as I mentioned, are one of them. So essentially here we do the same thing, but instead of clustering on overall activity, we do the clustering based on transition states. And you can see that essentially this is the observed minimally expected standard residuals from the chi-square. And this is essentially showing you that in green, the people who have less transitions, this is regardless of their overall physical activity, are more likely to have disease than those who have fewer transitions. Doing it the other way around, the ones with more transitions are less likely to have disease, right? Regardless of the overall amount of physical activity. So this is kind of a hot area, that the idea that we should ping people to get up and move around, even if it can't get you to go and do an hour activity every day. Maybe if your watch tells you to get up and move around after an hour, that could be potentially beneficial for your health. And so we explored that in the next study, which I'll show you in just a moment. So this was the first study, and really our major conclusions, which were it's feasible to do this. It's feasible to digitally recruit this number of people. We can use sensor-based measurements. It's easy to join, but it's also easy to leave. And that's one of the challenges that we also have been facing. This is not news, but again, people do like to compete with themselves and with each other. So at the beginning, we only had the 6-minute walk available at the end. When we made it available throughout the study, people like to do it multiple times and compete with themselves. So that's something that we had to kind of relearn, but it is, I guess, in retrospect, pretty obvious. And again, something that behavioral psychologists have known for years. People like personalized encouragement and personalized feedback, and you'll see that we fed that into the study that came later. Also, to the very first point, people are touching their phones all the time, but there are really very many calls on the digital attention span. And for a healthcare study to hold that attention, we probably are going to need to do more. The other thing is that, people are used to a seamless digital experience. So if your app is not as smooth as the other apps on the App Store or as Apple provide, then people are going to tell you that in the comments. So clinical researchers are not used to having to deal with comments, and so suddenly we were going every day to the App Store and looking at the comments on our app and having to move rather more quickly than we're used to in clinical research based on 1-star feedback. So that was a new thing for us. And then this part of that is also this, clinical science, software development, very different histories and different cultures, but actually the group of us in the room here are in perfect position to try to bridge that divide. All right, so that data is available. If anyone is ever interested, we made it publicly available. It's on the sign-up server here. You can go and grab it. I said I'd have one slide on genomics. Here it is. I think it's just one. We partnered with 23andMe, essentially, so that people, if they had 23andMe data, could essentially securely share that with Stanford and with the study. So we kind of instantly had a genome-wide association study, which is here for chest pain during physical activity. It's actually 3 slides on genomics. And the details don't matter, but just to say that we're able to generate a genome study essentially overnight by virtue of the fact that 25 million people now have genetic data on themselves and can download that and share it with the study. Now, I mentioned a study that was done in the 40s and 50s, the first one to put physical activity and health essentially on the same graph and show things like those were the days when we didn't know smoking caused cancer, or we didn't really believe that smoking caused cancer. Your doctor would be in advertising for cigarettes. We also didn't know that exercise cures all disease, which it basically does. This guy helped demonstrate that, Jerry Morris, who's a Liverpudlian, born in Liverpool in England, but spent most of his life in Glasgow, so he would sound a bit like me. And he demonstrated, among other things, that the bus conductors, that's why I was showing you the London buses, the bus conductors who walked all day had half the heart attack risk of the bus drivers who sat on day, and they shared the same environment. In a later study, he looked at the waistband measurements for the uniforms for those individuals. And so this was the beginning of essentially physical activity epidemiology. And you might be surprised to learn that low fitness is, in fact, a greater risk factor than obesity, smoking, and high blood pressure combined. So it's a very significant risk factor in activity. And in fact, this is my favorite statistic that I share with my patients. I'm kind of an annoying doctor because they tell me they don't have time to exercise. And I tell them that 1 minute of exercise is associated with 5 minutes of extra life. So you definitely have time to exercise because you're going to live longer. So the second version of the app, I'll share with you quickly. I'll go through it quite quickly here. We wanted to move more clearly towards a causal study rather than an observational study. And we ended up deciding to do a randomized trial. So this was the first entirely digital randomized clinical trial where we did prompts, different prompts like passive education. We thought of this as really a super control group. American Heart Association just said, please go look at the American Heart Association website. So that seemed like really just like control. We had personalized coaching, which is personalized to you based on your physical activity cluster. We had the classic 10,000 steps a day. You know, in this particular case, I think the person had 115 steps, still had some way to go to their 10,000. And then a continuous 1 hour sedentary trigger. So if you've been sitting for an hour, it would say, hey, you should get up and move around. Here are the demographics for the study. They absolutely mirror at the Apple user base, which is mostly males and mostly young. So we worked pretty hard against this, but we ran out of money with our Google and Facebook ad targeting. So the end study was still fairly pushed in that direction. This is a bit too small, but just to let you know, we had the same issue with engagement. About 80% of the users who started were not there at the end. And I'll get to the results. So the first thing is that people in this study and Americans in general don't walk very much. You can compare your own step count to this, but about 3,300 is about the average, and our watch data actually is a bit closer to that, so we probably are about average. The phone missed some of these, but the baseline is not very high. You can think to yourself whether it's likely that those little nudges were enough to change anybody's behavior. I'll give you a moment to decide what you think the answer is going to be. We thought that probably the hourly stand prompt would work the best, that the daily step prompt would probably work, and then the others were pretty unlikely to work. Go read the American Heart Association website, we thought would work not at all. In fact, it turns out they all worked, but not by very much, right? So there was a 10% improvement, which, again, glass half full, glass half empty. Every single one of these interventions, even just a prompt to go look at a website, and we don't know whether people actually did or not, but even just that prompt was enough to increase by 10% the step count. But we went from about 3,000 to about 3,400. So does that have an impact on health? Probably does if you do it in a large enough population, but a bit unclear. So here's a challenge and opportunity. I won't read these out because we're running out of time here. I wanted to tell you quickly about this patient of mine. He was sitting at home one day watching TV and eating pizza. He has a heart condition called hypertrophic cardiomyopathy. It's a genetic condition of the heart muscle. And you can see his heart moving here. It's a bit thicker than it should be. So anyway, his Fitbit then beeped at that point and congratulated him for being in the fat burning zone. And he thought, wait a minute, I'm sitting at home watching TV, eating pizza. I'm definitely not in the fat burning zone. And what actually ended up happening was he came into the hospital because he didn't feel completely perfect. He felt okay. It turned out that his Fitbit had essentially diagnosed, without even trying, a potentially fatal rhythm called ventricular tachycardia, which is what is shown on this 12-lead electrocardiogram here. So even without trying, these devices can actually pick up abnormal rhythms. We, with SAP a few years ago, built a discordance metric, which is to say we had users who had watches and who had other data from their electronic medical record. And if there was a discordance between their movement and their heart rate, then we essentially gave an alert. And if the two went in sync, then we did not. So if they moved and their heart rate went up, that made sense. Probably they're working out. If their heart rate went up but they didn't move and they weren't moving, then that's something that might be worthy of an alert. Turns out, our colleagues at Apple had a similar idea, but they rolled it out to about 40 million watch users overnight, which is just a whole new world for cardiovascular diagnostics. I mean, my cardiology colleagues across the country were like, what is happening? What is this world that we're in? So anyway, I think my time is up. I was going to tell you a little bit about this cool work that one of my grad students is doing with convolutional denoising autoencoders to look at rhythms from wearables. So if anyone's interested in that, come and talk to me. It's kind of a cool thing, but I ran out of time. Sorry, talked too much. And then this was the data from last week. If you saw the New York Times and others essentially, our collaborative study with Apple was released in the New England Journal of Medicine. And this was a study of 500,000 individuals, essentially 450,000, where we used not the AI system that I was going to tell you more about, but rather the system that Apple developed, which is based on tachogram measurements, which looks at just the difference in essentially the standard deviation of the difference between the two intervals of the heart rate. So it's a pulse notification. If you have an irregular pulse, they tell you you might have atrial fibrillation, and they connect you to a doctor. So it's shown here. But the key thing is that at scale, and so this was a study that was at scale of 500,000, but this algorithm is actually present in all the watches, which we would estimate to be in the tens of millions, maybe 50 million at this point, with a positive predictive value of around 0.8. It was able to detect atrial fibrillation, which is a significant rhythm of the top chambers of the heart that's associated with stroke. And stroke is one of the major health challenges of our time, particularly for rehab costs in the healthcare system. So these were the conclusions from that study, and essentially I think we're facing a world now where these devices are going to be on hundreds of millions, if eventually billions of individuals' wrists, and capable, at least in the cardiovascular domain, of helping them be healthier by doing more physical activity, by measuring fitness, but also by detecting abnormal heart rhythms. And in fact, you can go further and not just measure the LED signal, but measure the electrocardiogram as well, which has been present on multiple wearable devices for years, but again, very large-scale rollout with Apple's electrocardiogram, which now I have patients bringing me their ECGs from their watch on a pretty regular basis. So in conclusion then, I think both precision health, which is essentially the prevention of disease, and precision medicine, which would be the way of measuring disease more accurately in order to treat it more precisely, is being advanced by these kinds of tools. I think we have much more data. We have the ability to measure people in real time. Sensors are clearly better. Can we improve through behavioral nudges? Can we improve their health? I think we can. Can we engage them in a sea of digital attention-grabbing devices? Then I think we have to work a bit harder on that. But for sure, with a bit of thought, wearable devices can also detect arrhythmia and potentially reduce burden of disease. And this is potentially a worldwide phenomenon. So these are all the people who do all the work in my lab. This is the My Heart Counts team. There's one more slide here. There we go. And that's it. Thanks for your attention.
One question regarding those nudges. You noticed that people improved more steps, but was that consistent over a large period of time, or after a couple of days they went back to their normal low step count?
It's obviously a really good question, important question. This particular study, and I'm sorry I had to rush through it quite quickly, but it was a crossover study where essentially we used everyone as their own control. For 7 days we measured their physical activity pattern, and then we rotated them on a weekly basis into the different interventions randomly. So in this study, it was only designed to give us 7 days of data. So we can't answer that question with this study. But it's a really important question. And the study we're launching in the next few months, which will be in association with, actually with Google Cloud. So they'll be on the Android platform as well as iOS. And will be with the FDA under something they have now called My Studies platform, because the FDA is very interested in this technology for FDA-sponsored, on any study that's heading for regulatory approval. That study will be long-term follow-up, because it's the obvious thing to do next. We thought we would take the intervention that worked best and then go with that for the long, but they all work the same. And so probably what we will do is try to combine a couple of these and make it even more personalized. And then by asking people what are the things that really inspire you to be more active. For some people, they want to look good. For some people, they want to avoid the heart attack their brother had or their father, or they want to avoid Alzheimer's disease. There's lots of individual motivators. So I think what we'll do in the next version is include the individual motivators, have a longer term follow-up, and we'll also be on both platforms.
So you talked about the cases where the person went to the hospital and it was really something going on with the person. But do you have also information about false positives where they were, afraid of something, but actually there was nothing? Yeah.
So I think when the devices are not trying, that people just happen to be wearing them, and then it gives an alert, and so then they go. Those are sort of more in the realm of anecdote rather than studies. But one of the reasons that we were happy that Apple decided to fund this study is this was, a proper, again, registered with the FDA, proper clinical trial. And so the major focus of the cardiology community and the major focus of, honestly, everyone was on this question of false positives. So in this case, the algorithm is trying to pick up a specific rhythm, atrial fibrillation. And there was of course it's tunable, and we and many others had recommended to the engineering team there that we make sure that the false positive rate is low, even if that's at the risk of missing. And so, in other words, the precision has to be very high, even if the recall is low. And so, and I think that's okay, because at the moment, the people who are being picked up through this approach are not being picked up at all. So any improvement over that is clearly an improvement over where we currently are. Whereas if the precision is low and we have false positives, then that's a negative. In other words, we're in a situation where we're in a worse state than now. So it's the right way, I think, to tune the algorithm. So this is the answer to that question specifically. And you can see that the overall proportion notified, right? So this is in the big study, is 0.5%. But their worry was that lots of the younger people would end up being notified who, when they have a very low pre-probability of having atrial fibrillation. This is a condition that predominantly affects those as the decades go on. And so that number was significantly lower even than that at 0.16. The group who are really quite likely to have atrial fibrillation up here is 3%. Now there's no Bayesian analysis in this. There's no pre-probability built in. This is how the built-in algorithm responds, and it's as simple as those tachograms. Again, I had to run through it a bit too fast, I'm afraid, but here, it's really, this is the algorithm here, right? So there are periodic spot measurements where you look at the difference between the times between these different peaks on the LED waveform, and if they're irregular, basically the algorithm goes back and says, I'm going to check again. And then it checks again, and then if there are 5 confirmations, it notifies the user. So that number of confirmations can obviously be changed. So the important thing, and again, I'm sorry, I had to go quite quickly through this, but this is not a real-time algorithm. It's not looking at the rhythm, or at least at the sinusoidal LED waveform from your heart rate and deciding in real time whether you have a normal or abnormal pulse. The convolutional denoising autoencoder that I showed briefly there is designed to be a real-time. And at the moment, that's a grad student project that actually it seems to be working quite well. We're interested in putting it on a device. Actually, if anyone has a device, it'd be interested in trying it. Whereas this is all about taking the regular pulse and just essentially deriving a pulse and then saying what's the standard deviation of those measurements, and then basically depending on the answer, it then either does confirmations or not. And if it tries to confirm 3 times and then it's a negative and they have regular rhythm, then it just resets. So that's what the Apple algorithm is. So it's very, it's very conservative. It's only going to call if it really decides that over the course of several hours, you've been in atrial fibrillation the whole time. But I think that was a smart thing to do, because this is also the first major study of doing this kind of thing. And if there had been overcalls here, the whole medical community would have responded very negatively. Whereas, in fact, I think it's been quite positive press. And as I say, this was released for the first time, actually, a little bit of the data in March, and then it was published just this last week. So.
Thank you.
Okay, great, thanks.